Hi, welcome. Today we are diving into a topic that could mean the difference between life and death: pulmonary embolism. Imagine a disorder that strikes unexpectedly and can turn a routine day into a medical emergency within minutes. That sounds bad, but anyway, we will unravel the complexities, causes, diagnostics, and treatment of this disorder. Hit the subscribe button and stay with me. All right, so here from my perspective, we are looking at a great medical mnemonic which I created to help you memorize the types of embolism. This can occur in various forms, including fat embolism, right there, which is often seen from trauma such as fracture of long bones. We also see foreign body embolism that may be seen in IV drug users. Air embolism, right there, may also be associated with central line catheters. And amniotic fluid embolism may also occur during or after childbirth. We also see septic embolism, typically stemming from infections, and emboli resulting from a tumor lysis syndrome. Now let's take a look at the popular Virchow triad, which is crucial for understanding the risk factors associated with deep vein thrombosis as well as pulmonary embolism. It includes venous stasis right here. All right, and it is often evident in bedridden patients, those in the post-surgical period, individuals with an elevated central venous pressure, or those experiencing high viscosity states like in multiple myeloma, polycythemia, and leukemia. The second component is a hypercoagulable state, which is also very important, and this may arise from the use of oral contraceptive pills, hormone replacement therapy, nephrotic syndrome, or deficiencies of protein C and S, antithrombin 3, as well as factor 5. Trauma or vessel injury is a very important part of Virchow's triad, and here it is frequently observed in patients undergoing joint replacement surgery or extensive surgeries in general. All right, so deep vein thrombosis can be classified as occurring above the knee, which we're going to call proximal DVT, or below the knee, that's going to be a distal DVT. The important thing to note is that proximal DVTs are the most common source of pulmonary embolism, and DVT together with pulmonary embolism are often considered together as they are interconnected. So when a thrombus dislodges from the proximal vein, right there, what happens is that it may propagate into the vena cava here, okay, and then subsequently enters the right heart chamber. This is the pulmonary trunk, okay, and eventually enters the pulmonary arteries where it results in obstruction that is compromising gas exchange. All right, so normally air comes into a normal alveoli and the air contains oxygen, right? Oxygen is then exchanged for carbon dioxide. The oxygen is perfused into the arterial bed. So we can actually say that normally ventilation should match perfusion. That's very important, okay? But in contrast, as in pulmonary embolism, as you can see, this is an embolus. And what is happening is that this is obstructing the pulmonary arteries. So there is an ischemia. Even if this occurs in the distal areas, it can even lead to infarction. So what I want to emphasize on is that there is going to be an increase in alveoli dead space. That is, the oxygen that is coming in there is actually going to waste. Okay, this is called a wasted oxygen. So as we can see, right, alveoli ventilation, okay, that is the oxygen in the alveoli right here, okay, remains normal. In pulmonary embolism, that oxygen can even be increased. So we can also have hyperventilation. That is hyperventilation. Okay, this means that the level of carbon dioxide can even be low in pulmonary embolism, and there can also be hypoxemia, so oxygen levels are also low. All right, so in short, due to that dead space, the wasted oxygen, there is abnormal perfusion. There is no gas exchange. So when we say alveoli arterial gradient, what we mean is that in the alveoli, the oxygen there can be normal, or it may even be elevated, as in hyperventilation, but the perfusion of oxygen is abnormal or is decreased, which makes this gradient elevated in pulmonary embolism. However, this gradient can also be normal in certain cases. Another good way to express this is to say that there is a ventilation perfusion mismatch in pulmonary embolism. Now, in the case of a distal pulmonary embolism, that is, if this emboli right here propagates all the way to the distal part of the pulmonary artery due to the sustained hypoxia, certainly this would lead to an infarction. Okay, that means the tissues around this area will be non-viable. So this may be characterized by alveoli hemorrhage, and clinically this may present as hemoptysis and a pleuritic chest pain. Pleural effusions may also occur in pulmonary embolism. Now, as a result of the sustained hypoxia, the body tries to activate a neurohumoral reflexes, which actually leads to a series of pulmonary events. That is an increase in the peripheral resistance as a result of vasoconstriction. There is also pulmonary hypertension. All this can actually deteriorate the state of hypoxia and lead to pulmonary infarction. Now, the state of the lungs or the pressures in the lungs will be transmitted all the way into the right ventricle, leading to pressure overload state for the right ventricles. There is going to be a right ventricular strain, okay? And this can also be expressed as a weakened, overstretched, thin-walled right ventricles, which is not able to overcome the internal pressures sustained now in the right ventricles. As a matter of fact, what happens is that those pressures can even displace this interventricular septum in the direction of the left ventricle. If this pushes this septum into that direction, then this can lead to a decline in the preload. And this would mean there is also a decline in the cardiac output. So blood pressure, if you recall, is actually equal to cardiac output multiplied by the total peripheral resistance, right? And so if you actually decrease the preload, certainly you have decreased the stroke volume, okay? And so you have decreased the cardiac output, and then you have decreased the blood pressure. Hence, systemic hypotension may occur with massive pulmonary embolism. Again, you recall that there are certain branches of nerves, okay, that passes through the septum. And so if there is a displacement, this can certainly predispose to a right bundle branch block as well. So clinical manifestations of pulmonary embolism can indeed lack specificity and often presents with pleuritic chest pain, which may be accompanied by signs of deep vein thrombosis such as pain, tenderness, and edema in the extremity. Patients may also exhibit a cough and inspiratory crackles alongside hemoptysis due to pulmonary infarction. In more severe cases, massive pulmonary embolism can lead to systemic hypotension, compromising hemodynamic stability. Sudden dyspnea is common and may be accompanied by feelings of apprehension. On auscultation, P2 component of S2 sound is accentuated. Now, given this presentation, it is prudent to maintain a high suspicion for pulmonary embolism, especially when patients report pleuritic chest pain and hemoptysis alongside risk factors for this condition. In investigating pulmonary embolism, CT pulmonary angiogram remains an ideal diagnostic test modality, providing clear images of the blood vessels in the lungs. Although pulmonary angiogram was once the gold standard, it is now considered a historical gold standard. Ventilation perfusion scan remains a valuable tool for diagnosing pulmonary embolism. In the investigations for deep vein thrombosis, a venous ultrasonography or a duplex ultrasound can be extremely vital. MRI is equivalent to contrast venography, and D-dimers are very useful as they have a good negative predictive value. Other tests that may be important include a full blood count, urea and electrolytes, C-reactive proteins, ESR, glucose, bilirubin, and creatinine. It's important to recall that we said there is a right ventricular strain in pulmonary embolism. That is, the overstretched walls of the right ventricles can actually release BNPs as well as even cardiac enzymes to a certain extent. All right, so in cases of pulmonary embolism, the electrocardiogram often shows sinus tachycardia, which happens to be the most common electrocardiographic sign for pulmonary embolism. A distinctive pattern that might also be observed is known as the S1Q3T3, and this is characterized by a prominent S wave in lead 1, okay, and also a deep Q wave as well as an inverted T waves in lead 3. However, this is non-specific as well as not sensitive for assessing for right ventricular strain. Chest x-rays can often appear normal in pulmonary embolism and should not be used to rule out the condition. Some notable radiographic findings, although rare, includes Hampton hump sign, which is a wedge-shaped infiltrate, as you can see right here, and this indicates pulmonary infarction. Westermarck sign is characterized by a prominent, as you can see right here, okay, a prominent central pulmonary artery with the absence of pulmonary markings just distal to the embolus. This is also known as an oligemia. Additionally, X-ray may reveal atelectasis and pleural effusion. It is essential to maintain a high suspicion for pulmonary embolism, particularly in patients who present with sudden dyspnea and hypoxemia despite having a normal chest X-ray. All right, so let's discuss the management. Pulmonary embolism is a critical medical emergency, no doubt about that, and this necessitates immediate attention as well as management. In cases of a strong suspicion of pulmonary embolism, it is vital to closely monitor the patient while awaiting diagnostic evaluation. You need to also provide supplemental oxygen, and sometimes it is necessary to administer heparin when it is indicated. Now, once pulmonary embolism is confirmed, then you need to initiate anticoagulation therapy. This is essential to prevent further complications. This usually involves the concurrent use of heparin for effective bridging with warfarin, which takes approximately about 48 hours or longer to reach therapeutic levels, okay? Making a regular INR assessment very crucial. So, while both unfractionated heparin and low molecular weight heparin are effective options, low molecular weight heparin is often preferred due to its comparable efficacy and longer half-life, allowing for less frequent dosing. In the event of heparin-induced thrombocytopenia, it is crucial to promptly discontinue heparin to prevent further complications by replacing it with a direct thrombin inhibitor. For patients with massive pulmonary embolism, thrombolytics may be indicated, although they carry a significant risk of bleeding. Surgical treatment modalities can include thrombectomy, where the clot is surgically removed either through traditional methods or minimally invasive catheter-directed techniques in very severe or in patients that fail to respond to standard therapy, for example. Patients with deep vein thrombosis who also have a contraindication to anticoagulation, or those that are experiencing recurrent thromboembolism, the placement of a vena cava filter may be considered to prevent further clots from reaching the pulmonary circulation. And rivaroxaban is also recognized as an effective option for thromboembolic prophylaxis, particularly in situations where the risk of clot formation is elevated. That's very, very important. And also, rivaroxaban, this is due to its ability to inhibit factor 10A, and this provides a reliable means of preventing thromboembolic events in clinical settings when prophylaxis is deemed necessary. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.